In Module 3, Part 3 of Introduction to Diagnostic Medicine, we'll investigate some of the disorders related to red blood cells and white blood cells. Your learning objectives include describing the etiology, which means the cause of the disease or abnormal condition, and correlating specific hematology tests in diagnosing a small number of diseases affecting the red blood cells and white blood cells. These include anemia, sickle cell disease, iron deficiency and lead poisoning, leukemia, and infectious mononucleosis. We'll begin with anemia. Anemia is a term that describes a deficient number of red blood cells, and because the red blood cells are deficient, the hemoglobin is also deficient. So this is a general description of a disease, not a specific disease in and of itself. You can see by the graphic on this slide a visual of an approximate normal amount of red blood cells compared to plasma, an anemic amount or deficient, and then a polycythemic amount of red blood cells or too many red blood cells as compared to the plasma, and we can represent these by the hematocrit, which you should remember from previous lessons. We can categorize anemia as defective production, where aplastic anemia or a failure to produce cells in the bone marrow is the most severe. Excessive destruction, which could be caused by disorders such as a hemolytic anemia, which is a disorder that causes red blood cells to lyse or break up in vivo. And sometimes this is the result of disease or medications or even artificial heart valves. And it could be caused by blood loss, so acute bleeding as in an injury, or chronic bleeding such as through the GI tract, where somebody may have a gastrointestinal problem, a tumor, an ulcer. Most anemias are diagnosed with the CBC, complete blood count, and then followed up with confirmatory tests, since the CBC is a screening test and often will provide a start but not complete information regarding the diagnosis. Symptoms of anemia are depicted on this slide. Those that are highlighted in red are present when anemia is severe. And you can ask yourself, why would an individual exhibit these symptoms if they are anemic? So if a person is fatigued, what is missing? And the answer, of course, is the person is deficient in red blood cells and they have insufficient hemoglobin. What does hemoglobin do? Carry oxygen. If oxygen is insufficient, we can experience fatigue, we can experience respiratory problems, shortness of breath, experience muscular weakness, heart palpitations as the heart works harder to pump oxygen, deficient blood, pale skin, a cold feeling, and some of these other symptoms. Pause the video and click on the picture for a short tutorial on the role of red blood cells and anemia. I always encourage you to take the time to watch the multimedia resources. They support your learning and your understanding and your ability to correctly answer assessments. When we classify anemia, we can classify them based on the appearance of the cells. So they can be microcytic and hypochromic, too small and too pale. These are terms you should be familiar with now. Normalcytic and normalchromic, which is normal appearance, or macrocytic or too big. We can also classify anemias based on the etiology. So these include inherited hemoglobin disorders such as sickle cell, nutritional deficiency such as iron deficiency, or secondary to another disease such as cancer or treatments for cancer. When we talk about a differential diagnosis, we are talking about using tests to determine which disease is present. Many diseases, in particular anemia, can look similar based on screening tests. So the screening test would be a CBC. We would use additional testing to determine if a microcytic blood picture is due to iron deficiency or lead poisoning or something else. You can use the same logic when differentiating anemias that appear to be normocytic and anemias that appear to be macrocytic. Differential diagnosis is a very common term in diagnostic medicine, and most of these diseases we will not be addressing, and the full concepts are a little advanced for our class, but you should understand that many diseases present in a similar way, at least based on history, physical signs, symptoms, and screening tests. Sickle cell is a specific type of anemia. Sickle cell anemia or sickle cell disease is an inherited hemoglobin disorder. We call this a hemoglobinopathy. And what happens is there is an impaired production of red blood cells and an increased destruction because of the unusual shape that the cells take. This disease affects about 1 in 625 African Americans, people of African descent. So there are other ethnic groups where sickle disease or sickle trait might be present. And what happens is the hemoglobin, instead of being the normal hemoglobin A, includes a hemoglobin S molecule, and this S molecule polymerizes or forms chains in low oxygen tension and creates the sickle shapes, thus the name of the disease, and you can see pictures of this on the slide. I encourage you to, again, pause the playback and click on the picture for a brief tutorial about sickle cell anemia. The sickle cell gene can be inherited in a couple of different ways. It's actually an autosomal recessive trait, meaning that both parents would need to be carriers and or affected. So each parent would have to have the abnormal sickle gene. If the parents had 4 children and inheritance followed this standard pattern, one child would not have the disease or trait. 2 children would be carriers, and we would say they have the sickle cell trait, and 1 would be affected and would have the sickle cell disease. So carriers, or those with trait, are usually unaffected in day-to-day life. They may experience some negative effects of the sickle cell hemoglobin in low or high altitudes or extreme exercise. The child who is homozygous and has sickle cell disease will be impacted and will have lifelong issues with anemia, sickle crisis, and other issues related to the overt sickle cell disease. All 50 states now require newborn screening for hemoglobin S, along with many other disorders of hemoglobin and metabolism. This allows for early identification of people who are affected with sickle cell disease, and the picture that you see is an example of how newborn screening is performed, where blood is collected from a capillary puncture in the heel of the baby and applied to a filter paper. That paper then is sent to a central laboratory, usually a state lab of hygiene, as in Wisconsin, and then that blood is eluted from the paper and used to test multiple different disorders. In the laboratory, the diagnosis of sickle cell is made based, of course, on history and symptoms. This would be for people who have not been previously diagnosed. There's a screening test called a Sickle screen, and it's very simple. It depends on demonstrating the abnormal hemoglobin S. Hemoglobin S is insoluble in low oxygen tension, so a chemical is added. The blood is added to a chemical, and you can see from the picture the normal hemoglobin A is clear, and you can see the lines through it, and the abnormal hemoglobin AS is cloudy. This test does not distinguish between people who have sickle disease or sickle trait. It only demonstrates the presence of the abnormal hemoglobin S. So a positive screen must be confirmed with hemoglobin and electrophoresis, which is a test that looks at the individual hemoglobin proteins, or with DNA testing, which is a molecular analysis test. So again, this is a screening test, does not distinguish between individuals who have the disease or who are carriers and have the trait, and always is confirmed. Let's look at iron deficiency anemia. So iron deficiency anemia is one of the most common diseases worldwide. It's readily recognizable. Backing up just a bit, iron is essential for hemoglobin formation. So a decrease in iron results in iron deficiency anemia. We measure iron in serum or plasma as ferritin. Ferritin is the storage form of iron, and we see decreases in this storage iron or ferritin in iron deficiency. So insufficient iron is coming in through the diet. Eventually, iron stores are depleted and iron deficiency anemia results. This is almost never an acute disease, but could potentially be the result of a hemorrhage. Excess iron is not good either. So men or women who are past menstrual age typically do not require iron supplementation, and excess iron is toxic to the liver. There is a disease related to excess iron stores, and it's called hemochromatosis. This is a genetic disorder and ultimately does affect the liver of those who are affected by this disease. So what you should know from this discussion is that iron is essential for hemoglobin. If iron is not adequate in the diet, eventually the stores of iron will be depleted. We measure that stored iron as ferritin, and ultimately the disease that results is called iron deficiency anemia. Again, iron deficiency is a gradual onset in almost all cases. We deplete stored iron or ferritin. Ultimately, hemoglobin synthesis is impaired, and we can recognize this anemia very easily. You can see in this image a microcytic hypochromic red blood cell picture. We often compare the size of a normal red cell to the nucleus of a normal lymphocyte. You see a normal lymphocyte in this picture, and you can see that these red cells are mostly smaller than that and very pale in the center. So the red blood cell indices, the calculations that tell us about the size and hemoglobin of red blood cells, are low. The MCV, mean cell volume, is small, and the MCH, mean cell hemoglobin, is also lower than normal. This reflects the abnormal hemoglobin production related to deficient iron, just not enough raw material to produce normal red blood cells. So we might say, since this is such a common anemia, should we screen or not screen? So remember, when we talk about screening tests, we are talking about identifying disease in an asymptomatic population. So we'd have to ask ourselves, would people who are iron deficient be asymptomatic? And the answer is maybe, maybe not, but remember, this is a gradual onset disease. What populations would we screen? Who is most at risk for a dietary deficiency or chronic blood loss, either, which could lead to iron deficiency? and what do the experts say? So take a moment now and review the recommendations from the United States Preventative Services Task Force, the USPSTF. Their job is to review recommendations, outcomes, and other information related to screening tests in particular, and to give the public and practitioners advice on if a particular condition should be routinely screened for or what kind of testing should be done. So click on this link. You'll see some recommendations from the USPSTF related to iron deficiency. You should know this information because you may be asked to demonstrate your competency with an assessment or a quiz, but it's also extremely useful to begin to know how to use expert sources of information when attempting to determine health-related information, both personally and also professionally. So take a look and see what recommendations the USPSTF makes regarding screening for iron deficiency anemia. The last red cell issue or disorder we'll speak of is lead poisoning. So lead poisoning is not really a red cell disease, but lead poisoning causes abnormal hemoglobin formation. And the ability to test for lead is an example of how the diagnostic disciplines contribute to the evaluation of public health. So lead poisoning, lead contamination is a public health issue. We have heard examples of contamination with lead in the environment and in water, locally in Milwaukee and in other communities. Lead is a heavy metal, and it is typically found in the environment, and it comes from contaminants such as lead paint. Lead in paint was not banned until the 1970s, and older homes most certainly are painted with lead paint, and the flaking and removal of that paint causes contamination of living areas and soil. People also work with lead in their work. The battery industry is one that uses lead continuously. So those individuals also must be reviewed or tested for lead concentration in their blood, and that is required by the Occupational Safety and Health Administration, or OSHA. The end result of elevated lead levels in everybody, but this is particularly important in children, is impaired hemoglobin production and neurologic damage. In children, even small amounts of elevations in blood lead can result in long-term cognitive deficiencies and neurologic damage. Take a minute now to pause the playback and click on the picture for a tutorial about lead and lead poisoning. Lead levels are evaluated on blood. So blood samples are collected from the individuals who are either being screened, which would mostly be children. Remember, screening is testing in the asymptomatic population, or on adults who are being monitored for lead levels in their related to their workplace. Symptoms of lead poisoning include loss of appetite, vomiting, an abnormal walk or ataxic gait, convulsions, and coma. The radiograph that you see represents the long bones of a young person, and you can see the ends of these long bones are darker or more opaque, and that is due to a concentration of lead. So this individual had an elevated blood lead. Some of that lead concentrated in the bones of this person, and this lead is dangerous because it could mobilize at a later date due to stress or some other factor affecting the person, or due to pregnancy, where if this is a female child, and later could affect the developing fetus. So even though individuals who have lead poisoning can be chelated, or the lead removed from their blood, does not ultimately remove all lead from the system of that individual. The take-home message here is that childhood lead poisoning is 100% preventable, and there's many campaigns related to that. This one linked in this presentation takes you to a tutorial from the Centers for Disease Control related to lead. And again, the impact of the diagnostic disciplines in lead poisoning is the actual testing and monitoring of potential instances of lead poisoning, or screening for those who may or may not be exposed. We'll move on to white cell disorders. Just a handful of those. We'll talk about one that is common and benign, and that is infectious mononucleosis, and some that are dangerous and even fatal, and those are some of the leukemias. If we review our information from previously about the granulocytes, we know that the neutrophil, eosinophil, and basophil are the granulocytes, and they each have specific functions. These arise from a myeloid stem cell. So any of these could be involved in leukemia. Mostly we would see the neutrophils or the myeloid stem cells, but again, any cells could be involved or impacted in leukemia. Lymphocytes also, again, growing from or deriving from a lymphoid stem cell. There are some specific leukemias related to lymphocytes. And then we have our monocytes and macrophages. We'll begin this discussion with infectious mononucleosis. So this disease will come up again in our infectious disease section, so try to remember some of the details. Mononucleosis is caused by the Epstein-Barr virus. The Epstein-Barr virus is responsible for other diseases, including some leukemias. But in this case, we're looking at infectious mononucleosis. So it's a viral disease. Don't forget that. Most often diagnosed by symptoms. And most often this affects young adults or older teenagers. The symptoms include fatigue, lymphadenopathy, or swollen lymph nodes, pharyngitis, or a sore throat. The CBC would demonstrate a lymphocytosis, a leukocytosis, or overall increased white blood count with a lymphocytosis. So the increased white count is due to increased lymphocytes. And we'll also see characteristic reactive lymphocytes. You see on this picture normal lymphocytes on the bottom and reactive lymphocytes on the top. So these lymphocytes have been transformed by their exposure to the Epstein-Barr virus, and you can see they're large and their cytoplasm is kind of big and fluffy and bumped up against the red cells, and sometimes we say it looks a little bit like a ballerina skirt, so that's morphology. So that characteristic morphology and a lymphocytosis is often sufficient to diagnose infectious mononucleosis. If there is additional testing required, we could do a serologic or a blood test looking for immune response to the Epstein-Barr virus, and that would be a mono test. Again, this is a pretty self-limiting disease. It's very difficult for people when they have it, but there's no antibiotic because this is a viral disease. It's spread by saliva, so young people, all people are encouraged not to share drinking straws and water bottles. And of course, saliva is shared through kissing, so sometimes infectious mono is called the kissing disease. A more serious concern with infectious mononucleosis is splenomegaly. So splenomegaly means that the spleen has enlarged, and that enlarged spleen is fragile. and very vascular. A lot of blood flows through the spleen. So for this reason, individuals who are diagnosed with infectious mononucleosis are restricted from contact activities, contact sports, because of the danger of a ruptured spleen or damage to the spleen. And sometimes it's hard to make the correlation between infectious mono and that's splenomegaly, but that is the reason that usually individuals will have to avoid contact sports for a period of time after their diagnosis. The more serious diseases affecting the white blood cells are leukemias. So these disorders arise in the bone marrow. Leukemia means a cancer of the blood. So these represent circulating abnormal white blood cells. Essentially, leukemia is an overproduction of white blood cells, leuc meaning white, and emia of the blood. These cells will be abnormal. And ultimately, there are so many of them that they interfere with organ function, accumulating in the spleen and other organs, and they also interfere with the production of other blood cells. So if you think of a normal bone marrow, where the cells are somewhat spread apart and diverse, in a leukemia, there will be an overabundance of a certain type of cell, and ultimately that cell crowds out the other normal cells and they become deficient. So the person becomes anemic, thrombocytopenic. Anemias can be acute, meaning they come on quickly and end quickly, or chronic. So a slower course, often a much longer lifespan once diagnosed, and represent the myeloid line, so the granulocytes, the lymphoid line, lymphocytes, and the erythroid line, or red blood cells. So again, leukemias can affect any of our blood cells. The diagnosis and classification of leukemia is largely done through laboratory testing. It's important to be able to distinguish leukemia from reactive types of disorders and also from other disorders of the bone marrow. So careful examination of the peripheral blood is important. The CBC, our panel at general tests, would typically show a leukocytosis and a anemia and also a thrombocytopenia. And what we would see in the peripheral blood smear should be immature cells that have not progressed through the entire maturation process, and also abnormal appearing cells and abnormal red blood cells. A bone marrow biopsy and aspiration is almost always required. Remember, white blood cells, all blood cells, originate in the bone marrow, and the bone marrow gives us a very good look as to the type and number of abnormal cells being produced. Following that, so backing up just a bit, many immature cells look a lot like each other, sort of like babies often look a lot alike. So these baby cells or young cells need to have additional identification, and cytochemical stains, which look at the actual chemicals contained in those cells, immunophenotyping, which looks at antigen markers related to specific cells. That's a very important feature of diagnosis. And then molecular or genetic testing, looking at the specific genetic variants of these cells. Each of these help us to identify the type of leukemia and classify it, and then drill down into the specific genetic variation, which allows for precise treatment and also precise information about prognosis. Symptoms of leukemia are fairly general. They include things like weight loss, shortness of breath, weakness, swollen glands, swollen lymph nodes, splenomegaly, and some other things such as evidence of thrombocytopenia, like petechia and bleeding, bruising, and then maybe night sweats. So you can see these may or may not lead us to consider leukemia, but they're often present. This CAT scan, CT scan, shows you an example of splenomegaly in an individual with a chronic lymphocytic leukemia. The spleen is circled, and you can see how, I would tell you, it is very large compared to what it normally should be. Speaking of genetics and molecular diagnosis, genetics and cytogenetics are fairly young in terms of science. The more advanced technologies available to us now have resulted in the ability to stratify patients into risk groups and allowing us to use targeted therapies and better information for the patient. The genetic aberrations related to leukemia are complex. Here are two genes, 16 and 9, that are implicated in acute leukemias, and there are more. But you can see from the lists here related to these genes, the potential diseases related to variants or abnormal alleles in these genes is very substantial, and you can also see the number of base pairs related to each of them. So ultimately, as we get better and better at identifying these genetic variants related to diseases, we'll be able to deliver what we would call precision medicine and ultimately allow for safer treatment and improved outcomes. We'll talk a little bit about 4 main categories of leukemia, beginning with acute lymphoblastic or lymphocytic. So acute means that the cancer is fast growing and is best identified with early detection and treatment. Without treatment, the person won't have enough healthy bone marrow to recover, and the bone marrow will be replaced by these rapidly growing lymphocytes. And then the lymphoblastic or lymphocytic means that the cancer is affecting the person's white blood cells. And again, we've defined leukemia as a cancer of the blood. So most people with acute lymphocytic leukemia have a B cell subtype. There are about 6,000 new cases every year, and only about 20% of these are adults. So this is a childhood cancer. Known risk factors include exposure to radiation, chemical exposure, some viral infections. Mostly this happens outside of the United States, and some genetic conditions. In children, the 5-year survival is very good, 98%. But when we combine adults and children, the 5-year survival is 69%. And in terms of acute leukemia, this is still pretty good. ALL develops from the lymphoid blast, so one stage beyond the stem cell. And the picture on this slide shows you a peripheral smear full of baby lymphocytes or immature lymphocytes. And you can see there's many of them, and they all look pretty much the same. So the cells are lacking differentiation. That's often a very strong indicator of a leukemic process. Acute myelocytic leukemia affects the myeloid cell line or the granulocytes, and the AML cells can develop at the stem cell or the blast stage. That's a little bit beyond what you need to know for our class. And you can see in the peripheral smear, again, a proliferation of what we would call immature cells. Many of them, they're large, they all look kind of the same. There's a lack of differentiation. This leukemia is more common. It's the most common diagnosed leukemia. 19,000 about new cases every year. This is a disorder of adults, mostly older adults, and there are many variants. So acute myelocytic leukemia has many, many different flavors and names. Again, known risk factors are radiation and chemical exposure. We add in smoking. The 5-year survival rate for people diagnosed with most forms of acute myelocytic leukemia is only 27%. Some are very, very treatable if diagnosed at a very early stage, and some are almost impossible to treat. Many require a bone marrow transplant to overcome acute myelocytic leukemia. We'll look at the chronic leukemias together, and just as with the acute leukemias, we can have a myeloid origin or a lymphocytic origin. Chronic myelogenous leukemia is also a disease of mostly middle age and beyond. In this case, there are as an increase in the granulocytes, neutrophils, and there be a mixture of mature and immature cells. This disorder is characterized by the Philadelphia chromosome. The Philadelphia chromosome is a translocation between chromosome 9 and 22, and it produces an oncogene. So the oncogene allows the leukemia to develop. The Philadelphia chromosome is fairly well known and was one of the first genetic aberrations identified related to leukemia. There is a standard of care for newly diagnosed patients with CML, and this anti-cancer drug can be taken at home. It actually interferes with the ability of the abnormal cells to reproduce and live, and that's one of the problems with chronic leukemias is the cells do not exhibit normal cell death or apoptosis, so they accumulate and live on and on. The treatment allows patients to keep the disease in check and allows them to live with CML as more of a chronic and manageable condition. So as we've learned more about cell physiology, we've been able to develop very targeted drugs that interfere with specific steps in the cell metabolism or cell reproduction, and that's what this one does. So it's really quite a nice advance. Chronic lymphocytic leukemia seems to be of unknown causes. Again, almost always affects older adults, and has some more commonality in certain groups than others. It results in an increase in mostly mature lymphocytes. People often live with this disease for many, many years, and their death is due to something other than their chronic lymphocytic leukemia. This ends our kind of overview of some disorders related to red and white cells. Gives you an idea of common disorders, some that are genetic in origin, some that are benign and sort of self-limiting, and some that are not. You should take the time to review additional resources on blood disorders that are linked in our learning management system. There's a quiz associated with this module, so you'll want to repeat that and then review the module guidelines for any assignments or discussion. And as always, the syllabus will also help you determine what your steps should be to complete this section.